Hi, everyone, and welcome to OT Echo. I'm so excited today because Dr. Divya Desai is here to talk about Parkinson's disease. Thank you so much, Divya, for joining us. We are so welcome and so thankful to have you.
Thank you so much for the opportunity. Well, welcome everyone. My name is Dr. Divya Desai. I have been an occupational therapist for many years, and my first degree in occupational therapy was actually from India, where I received bachelor's in occupational therapy. So this seems like full circle that I get that opportunity to connect with other practitioners at this level. So I'm very thankful, Dr. Kate, for this opportunity as well. So very briefly about my background, why Parkinson's disease. I have been treating a lot of clients with Parkinson's disease in the past few years, and a couple years ago, I obtained this certification called LSVT Big, and I've seen some tremendous results, and I feel very passionate about sharing that with anyone who will actually talk to me and listen to me. So with that said, we'll get started. So today's learning objectives are to identify 4 motor and non-motor symptoms associated with Parkinson's disease, analyze the impact that motor symptoms have on occupational participation, evaluate effectiveness of high amplitude and high intensity exercises and fall prevention, and explore low cost and no cost treatment options that you may be able to implement in your clinical practice starting tomorrow. That's really what I was trying to go for. So before I proceed, I would like to learn a little bit more about you participants as well. So if you can use the chat box, if possible, please share how often do you treat a patient with Parkinson's disease? Is it once a week, once a month, or are you just here out of curiosity, but this is not the primary population that you work with? I would like to learn a little bit more about you. Daily, never. At least once a month. Once a month. Got one patient living with Parkinson's since I started practicing. Okay. Well, I do appreciate your interest and enthusiasm. If that's not a common condition you're working with and you're still interested in knowing, I do appreciate that. So those of you who are, say, working daily or once in a while, what are some challenges that you see your patients seem to experience? Is it a lot of tremors? Is it bradykinesia, fall risk? What are some challenges that they experience? It's ADL difficulties due to tremors.
For those of you outside the US, SNF stands for Skilled Nursing Facility.
Falls and mobility, correct. Tremors and freezing, high fall risk, rigidity. Great. Those are all the things we will talk about today. So then what are some interventions that you incorporate? Mm. Dual cognitive interventions, okay. Range of motion, adaptive eating, music to facilitate walking. I like that. Walking some distance. Functional training, ADL retraining using assistive devices, use of environment, wheelchair positioning for late stage PD, correct. Okay. And then what are some challenges that you experience as a therapist? And I hope that I can address those concerns to the best of my capacity. Slow, if any, progress. Okay. Plan denial or lack of awareness of problem, lack of carryover by caregiver. Lack of community resources. Complex discharge. Okay. Well, thank you for that information. We'll help bring our PowerPoint back up so we can talk about some of the challenges that you just described. Okay, so before we get into those nitty-gritty, just a quick overview of the pathophysiology of Parkinson's disease. Here we have our striatonigral pathway, which essentially starts with substantia nigra, which projects into the striatum, which will eventually project into motor cortex. Now, in case of Parkinson's disease, there is dopamine depletion, which weakens some of these pathways. And the two important ones that we look at are direct pathway and indirect pathway. So for you and I, for us who don't have the diagnosis of Parkinson's disease, the direct pathway is supposed to cause motor activation, and indirect pathway is supposed to cause inhibition of motor cortex, and they have to be balanced. Now, in case of Parkinson's disease, the direct pathway that's supposed to cause motor cortex to activate is weaker, which translates to difficulty with motor activation. And the indirect pathway is actually much stronger, which results in inhibition of motor pathway. So there is a lot of inhibition of motor cortex. And to add to that, motor cortex has a very challenging time getting activated, which results in a lot of motor symptoms that we kind of just looked at. So symptoms wise, I'm sure you've probably you've seen this Parkinson's iceberg where there's so little that we see with our visible eyes, and so much that gets unnoticed because we don't know this patient all that well. So tremors, rigidity, partial instability, those are some typical symptoms that can be seen on the exterior. But other issues like GI symptoms, pain, depression, hallucinations, delusions, the loss of smell, those symptoms kind of get unnoticed, but they have such an impact on the patient. We cannot really isolate those two. So part of the education, when you have that difficulty carrying over with caregiver or the client being in denial, some of those invisible symptoms may be contributing towards that denial. Speaking of denial, actually, apathy is also very common in the late stage of Parkinson's disease, which may also be contributing to the client's due to patient's denial, why they don't want to accept that this is what's happening and I need to make some changes. So for rest of the session, I will be focusing on addressing motor challenges because we have such little time. Some of the motor challenges include impaired balance, bradykinesia, hypokinesia, and tremors. So bradykinesia has to do with the speed of the motion, and hypokinesia has to do with the amplitude. So the research highly supports use of high intensity and high amplitude exercises. And that's kind of what I do when I'm working with my patients with Parkinson's disease as well. So the picture that you're seeing on the side, I use that in my practice as well. And here's how I explain it to them. If you looked at it as a graph, and this was like your horizontal axis, the x-axis, this is where your speed or your amplitude should be when you're moving around in space. But when someone has Parkinson's disease, they are not operating at this level. They are below that line. So their amplitude and their speed and their the way they move, it's much small or really small. And that's why I have that arrow pointing bit below the normal movement saying this is where you are. And therefore, when you push your patients to move big, you're actually trying to bring them from small to normal or very small to normal motions. And that's why we use high intensity and high amplitude exercises. So one take-home message, if you were to take the one and only thing, that would be this first bullet point of asking your clients to think about moving big and then actually moving big. And we're going to practice that. So to stop the screen share. Those of you who have the ability, if you can turn the camera on, and I will ask, when I say go, I want you to stand up from your chairs. Wait for everyone to turn their cameras on. Okay, so those of you who were able to get their cameras on, go ahead and stand up from your seated surface and let me see you move. Right, and have a seat back down. My question to you would be, was that your best and hardest effort in standing up? Most likely not, because I just asked you to stand. I didn't say anything. Now I want you to visualize something. Say you just sat down on hot bleachers or a chair that's sitting in the sun for a very long time and you just sat on it. It's hot. You can't stand sitting there any longer. And now you're ready to stand up. So with that image in your mind, go ahead and stand up again. Okay, so you see the difference between two motions. This is how you want to cue your patients when you have them move from one position to another. Some of these functional transfers and transitions are very hard for them. So when you help them visualize big motions, the way I kind of use that example of sitting on a hard chair or hard bleachers, it connects, they understand what you're asking of them. And when they push their maximum effort, they move with a lot of ease. They may think that they are struggling, but just switching the way you're giving your cues has a huge impact on how they're going to move around. So with that piece of information, my question to you would be, can you see how you can apply this in other aspects of your interventions, not just sit to stand transfer? If you can share some of that, we can have some great discussions, more examples of where you can apply this technique. Anyone? Oh, it looks like I'm hand to mouth. Oh, that's from previous. So you can use this technique in many other movement transitions, such as sitting up from or getting up from bed. If they are struggling to just perform that supine to sit transition, you can kind of use different cues to help them understand how to move better by moving bigger. So bigger is better. So you can use that technique for supine to sit transition. If they're sitting on a toilet seat and they're having a hard time standing up from toilet seat, you can use the same cueing to help them move big. When they're walking, you can have them practice walking big, and it's something we're going to do in a few minutes anyway. But any activity that you are doing with them, you can easily incorporate that additional cue of moving bigger, think big and move big, and you will see literally immediate results of changing your cues on their movement patterns. So let me pull back our PowerPoint slides again. Do you have any questions so far? Any thoughts? No? Okay.
Hello,
So, yes,
can you hear me?
yes.
Something that I find working with my clients with Parkinson's is that the cues of move big, they
Mm-hmm.
don't seem to sustain. So in the moment, in the session, yes,
Mm-hmm.
they respond to the verbal cue,
Mm-hmm.
but independently in their own space,
Mm-hmm.
it just doesn't. And so I don't know what to do besides repetition forever to help that cue stick, but I don't see that sustaining over time.
Okay.
Mm.
Repetition, yes, I agree. Repetition is the cue. We are literally and there is a question on the side as well. What is the rationale for using big movements? I'll try to answer those together. Repetition helps, but we are also trying to recalibrate some of their motor pathways in the brain. In their brain, they've assumed, or the brain has assumed that their movement patterns are normal. And here you come in and asking them to move crazy big. They are thinking, well, this is silly. Why would I walk like that? Or why would I move like that? So sometimes taking a video of them normally walking in comparison with how the big walking looks, that may shift their understanding and perception. But the question here is, are we concerned about them buying in, or are we concerned about them retaining? So that's where some of the practice comes in picture. You can give them home exercises, you can see them more frequently, and that may help stick some of the changes that you're having a harder time getting them to accept. I do have a follow-up question. How often are you able to see those those patients?
Depending on their insurance, it could
Mhm.
be 3 times, 4 times a week.
Okay, well, that's
Yeah, I have one that I
that
can only see once. Yeah.
okay. I see. So insurance kind of dictates how often you get to see. The more, the better, and that's the approach I use as well, 3 to 4 times a week for 4 weeks in a row. But I also give them homework exercises, and when I see them back again, I do have a conversation about, did you really do the homework? And how did it go? And eventually you'll know if they're doing the homework or just telling you that they did it or not. So
Yeah.
so you are right. You are doing what you're doing. Maybe we just need to think about, are they not buying in, or are they just having a hard time remembering it? And if remembrance is a problem, if they're open to it, and I've tried this technique as well, putting different post-its or reminders in different places in their house. So say they are struggling in their bathroom, having a little reminder where they can see it, where it says stand up big, that reminder is maybe all they need. So going back to the root cause of, well, thank you for asking that question. That was good.
Thank you.
Yes, you're welcome. So who asked the rationale for moving big, I hope I answered that question, but really what you're trying to do is in their, like I said earlier, in their brain has perceived that they are moving okay, and you are trying to come in and have them move bigger. The graph that I used earlier, you're trying to have them go back to the normal pattern. So when you tell them to move big, they are going from very small to small and then small to normal or ideal movement pattern. That's why you're having them move bigger. So I hope that answers that question. Okay, I'm sorry. It looks like my volume is a bit too high. I'll soften up.
I think you sound great.
Okay. All right. Well, thank you. Next treatment idea is dual tasking. Well, no, I didn't finish this part. So practice is necessary for recalibration, and we do want to work with them at least 3 to 4 times a week, because 1 or 2 times a week will result in what we talked about earlier. They will forget about it, or in the beginning, they will move big, but as the day goes by, they're getting tired and they'll forget about it and start moving smaller. So seeing them more often is a key. Check often when you are working with them, check often and ask that question over and over again. Is this your best effort? Are you moving big as you possibly can? And then making it fun, tapping into that intrinsic motivation. Then I want to talk about dual tasking a bit more. And I saw that someone in the group is already using that technique. So dual tasking is when you are combining cognitive and motor components together. And typically our patients with Parkinson's disease struggle with that. So much of their attention is spent towards planning their motor movements because of motor cortex inhibition. When you add a cognitive component, it's extremely challenging. That's when they slow down, and that's when they make mistakes. That's when freezing happens. But it is essential that we incorporate dual tasking. In some simpler ways, I incorporate dual tasking is by counting backwards, naming all the men in the household, all the women in the household, counting, well, I said counting backwards, describing a traditional recipe, talking about a life event that is significant to them. So when that happens, you are again reminding them, keep moving big as you are talking, keep moving big as you're counting backwards. And we do need to train them on dual tasking after they start showing you that they can consistently show those big motions. So we'll do a quick practice. Again, those of you who are able to, if you can turn the camera on, and when I say go, you will stand up big and then start marching. So all of you who are able to, just stand up. And I do thank you for participation. All right, so when I say go, march with big arm motions and big stomping of your legs. And keep going a little bit longer. And now I'm going to add that element of dual tasking, where when I say go, keep marching, but now you'll say the months from December to January backwards and see what that does to your motor performance. So go, start naming the months backwards. And stop and have a seat and share the difference between two motions. Did you slow down? Did you have to think hard about the months? What was the holdup? Slow down, correct. So if that happens to us, that's very likely to happen to our patients as well. Think hard and legs didn't move as much. Slow down, hard to do. Correct, by all means, it's a dual tasking. Now you're trying to do two things, and that's how we are challenging the motor cortex. And our patients need that too. Just going back to the PowerPoint. Next concept is breaking down the task. And now I'm using that as an example to show how I would progress from very simple task to get our patient to do more complex activities. So I'm using going to church as an example. If that's my patient's goal, they want to be able to go in that crowded space, walk sideways to get to their seat and sit down. In the beginning, I would just practice walking big in an open area. Just practice walking straight, walking sideways, and then practice walk and pause and walk again, because starting the motion and controlling the motion, those two tasks are challenging. So practice walking on cue. So you're walking with them, they're practicing walking big. And suddenly when you say stop, they have to immediately stop and not lose their balance. And then when you say start, they have to start right away while practicing the big motions. Then practice walking over small objects. So anything you can find anything that you can really find, just lay those items out on the ground and have them practice stepping over small objects, like how you would have to step over people's feet. So practicing that skill, and then eventually practicing walking in the crowded area. So this is how you would progress them, teach the underlying skills first, and then translate that to actual work and actual functional environment. And feel free to sprinkle dual tasking wherever you feel like they're ready for that challenge. So in this example, I've said dual tasking at the end, but you don't necessarily have to wait till that step. You can do dual tasking at the very first step where they're just practicing walking big in open big areas. You can add dual tasking whenever you feel like they're ready to try that out. Freezing, I know that was brought up in the chat as well as a very common occurrence. It's scary it's scary for them when they are frozen, and it is one of the most common motor problems. So the strategies, I kind of broke them down into two parts: what to do during freezing and what can you do to prevent freezing. So when your client is frozen, these are some of the things you want to tell them. Don't fight it. That's the immediate instinct when your legs are not moving and they are struggling and those feet are just shaking on the ground. Just relax, let it go, pause, maybe take a few deep breaths. Instead of struggling to walk and lose your balance, it's better to slow down a little bit. And when you feel like that moment has passed and you're ready to walk again, don't jump into walking already. Maybe weight shift side to side in the standing position. So instead of forward weight shifting that you would have to do, you're doing weight shifting sideways. Once you do that, then visualize your big motions. So going back to the one bullet point that I was referring to, think big and then move big. So doing that technique may instill a sense of confidence in them. If they can do all of those steps and they can see, oh yeah, this works, I'm not falling anymore or I'm falling less often, it may instill that confidence. And a lot of our issues are related to fear of falling. So building confidence is a big deal. So that's what you want to do during freezing. And there are a lot of strategies that you can implement to prevent occurrence of freezing. So counting, and in the beginning, you can count out loud, but as they get comfortable, they can count in their head as well. So just saying 1, 2, 1, 2, 1, 2. And I know someone mentioned that in the chat box as well. So counting in mind may help reduce occurrence of freezing. Focusing on a distant target also helps. Our patients typically have their eyes pointing down, and that can be one of the causative factors for freezing. So actually having your attention far out, making sure there's nothing on the floor that's going to make you trip and fall. Once your path is clear, there's really no need to keep looking down. Focus on a target that's much higher, much further, and that may decrease the occurrence of freezing. Walking to your favorite music, that was also brought up in the chat. That's an excellent technique to use your auditory cortex to redirect your motor patterns. And it works beautifully when they can walk to their favorite music. And the most important one actually is practice walking through the freezing triggers. What I mean by that is, if your patient has certain areas in their house where they are very likely to freeze, maybe it's a little dark corner that they have to turn to go from one side of the house to another, practice these techniques in those areas. In a safe environment, they can practice all of the techniques with you. And when they see, well, yeah, the techniques work and I'm not getting stuck as often, that will instill confidence and they're less likely to get frozen in those spaces in their environment. So a lot of education goes into this, where I wrote down some triggers for my notes so I don't forget to talk about it. Taking small steps is a trigger. And in my personal experience, I have almost never seen a patient experience freezing when they're walking big. It's almost impossible. So educating them that your small steps are a trigger for freezing. Your slow speed is the trigger for freezing. Stress, anxiety, fear, all of those are triggers for freezing. And if we can alleviate some of those triggers, your quality of walking will be better and you won't be so scared of falling all the time.
Dr. Divya, there's a question in the chat. With a person having trouble with a movement, would you start by practicing until they're big and then add the cognitive component?
Absolutely, yes. You don't want to add cognitive component in the beginning. You want to take all of that cognitive need out of the equation. So if you are in a busy therapy clinic and they're having a hard time doing their big motions, that's an indicative that cognitive component isn't working. So absolutely, you want to nail down the movement first before adding cognitive component to it. Thank you, Kate. So a little bit about the certification that I received. It's called LSVT BIG. It stands for Lee Silverman Voice Treatment. And it originally started for speech therapists, having them speak in louder volumes and such. And then the protocol was modified for occupational and physical therapy professionals. And that's what I use in my daily practice as well. It's a very structured approach where you have a set of exercises that the patient will do. You see them 4 times a week for 4 weeks. Each session is about 60 minutes, and it has homework exercises as well. I would encourage you to at least look through the website and reach out to them. I've learned they weren't able to give me exact information on that, but I've learned that they do offer discount for therapists outside of USA. So it's worth an ask if this is something you want to train yourself with more details. And yeah, I'm not getting any commission out of it, just letting you know that this exists if you are interested. And there is more. Exercises is just a small part of what we do for our patients. You want to look at their home environment. That was brought up in the chat, removing different obstacles, obvious things that are causing them to fall often. Those triggers, anything in the home environment that's a trigger for freezing, we want to remove those. Also explore non-sedentary leisure, because sitting down because of fear of fall is just perpetuating that negative cycle of inactivity. So exploring other leisures that will require them to get up, move, and always move big. And looking for opportunities to move big. For instance, playing drum is an excellent activity. You just need 2 sticks and something to bang it against. And that bilateral coordination is so good for their motor activation. Playing cricket if you have access to a bat and a ball. Dancing, don't need anything. We can sing on our own and we can do our own dance. Throwing a ball. Boxing, again, you don't need boxing gloves or a punching bag. You can just pretend that you're pushing hard, having those big arm motions and crossing midline. Farming, pulling water out of a well, or using the water pump. All of those are such great places where you can incorporate big motions. So I want to save some time for case study. If you have any questions, I can answer right now, or we can go right into the case study.
Let's do the case study.
Okay. All right. So let me pull that up. All right. So we have Mr. T. He's a 73-year-old gentleman diagnosed with Parkinson's disease about a year ago. Oops. Can you see my screen? Okay, so he currently resides in a small house with his wife, and his primary issue is feeling unsteady when walking in and around the house. He sustained 2 falls in the past 4 months, and wife reports that he sits a lot. Every day he wakes up in the morning, stays in bed until the wife is ready to help him out. He needs help putting the pants on, difficulty getting up from the toilet seat. He likes making his breakfast, but feels unsteady, especially when he has to reach up higher to the higher shelves. He watches a lot of TV until lunchtime, occasionally meets his friends for lunch, but attends Sunday church on Zoom, takes a nap in the afternoon, and then watches some more TV upon waking up. Dinner is around 7 p.m. and then he sleeps around 9 after reading a book. And his only physical activity is mowing a lawn once a week. OT evaluation. Mr. T needs 25% assistance with lower body dressing and getting out of bed. He ambulates with his feet shuffling on the ground and experiences freezing when going from one room to another within the house. He also tends to look down at the floor when walking. His shuffling is exacerbated and it's when he's distracted, such as having a conversation with the therapist. And he also reported feeling tired at the end of OT evaluation, which tells you that he's not active at all. His goal, he reports that he doesn't feel steady and would like to move better in his house without worrying about falling. And he's ready to explore some more leisures. And here is his home environment. There are 2 steps to enter the house. There are no railings on either side. TV is in the family room. And it's a step down from the kitchen area. And this is where he has fallen the 2 times that he fell. So this is a big fall risk area for him. He has a standing shower, which I have marked as a triangle here. This is the standing shower with a 3-inch lip. He currently uses a towel rod for support to get in and out of the shower. This is the toilet seat, which is standard height. And then there are 3 steps to enter the backyard where he goes once a week to cut the grass, but there are no steps in there. So that's our case study. And here are the 3 questions that I would like you to discuss in your groups. Identify 4 issues that are contributing to his fall risk factors. He currently cannot purchase any equipment for home modification. So identify 3 target areas in the home where you'll have him practice those fall prevention strategies and create 3 interventions that are geared towards reducing fall risk factors, and just have some detail to your interventions as to how often you'll see him, where will you incorporate those big motions, how will you introduce dual tasking, and will you give him any homework exercises? So I know we are running short on time, so hopefully we can still get some meaningful discussions. All yours, Kate.
Okay, welcome back, everybody. We hope that you had some great discussions. I know that it was probably a little bit short and you guys might not have gotten through everything, but we'll discuss with what you guys have gotten so far. So the first question was identify 4 issues contributing to his fall risk. David, we'll start with you. Can you name 2 that your group came up with? Oh, you're on mute, David.
One was that a lot of the stairs didn't have railings. And the second one was that they transferred in and out of the shower using a towel rod, which was probably not strong enough to hold on to. Those are 2 we identified.
Very nice. Antonius, did your group get anything different than those 2?
Well, we mentioned the less physical activities he's engaging in, no active lifestyle, lack of physical prompts or assistance to carry out tasks, and the home environment, which may have many stairs indoors and outdoors.
Good. And so that seems like a pretty comprehensive list. Aika, do you have anything that's different?
I think we have one which is different apart from the mentioned one, the 3-inch lip in the bathroom. My group said it's too steep. We can modify that into more like less steep to prevent fallings. So that was the different one.
Good. And I'm just trying to see. Tulu, did you come back? I don't know if you did. So we'll just move on to the next question. The next question was, he currently cannot purchase any equipment for home modifications. Identify 3 target areas in the home where you will have him practice fall prevention strategies. Aika, let's start with your group this time.
Okay, so the areas that we discussed, we guessed that we could use the dining room or the guest room because it has less things inside there, and we also thought of the backyard. Those are the two areas that we could identify.
Okay. Very nice. Let's see. Tulu, if you're back, we are on question number 2. We are currently seeing if you identified any target areas in the home where you can have them practice fall prevention strategies.
She was on a minute ago, but
Was-
she just took herself off camera.
No
So
worries. I'm like, I can only see like half the screen at a time. David, did you have any suggestions?
Well, getting up off the toilet, the sit to stand from the toilet was another. And then the stairs, going up downstairs, making big steps, going up and downstairs.
Nice. And then last but not least, Antonis, did your group have anything different than the different rooms? The sit to stand
Actually,
toilet?
not. We had the same answers.
Perfect. Well, everybody was on the same page. So we'll move to the last question, where you were tasked to create 3 interventions geared towards reducing fall risk. So Antonis, did your group create at least 1 intervention?
Well, actually not. We weren't able to make it in time.
Sorry
Okay.
about that.
It was a quick turnaround, but no worries. David, did your group?
Our group suggested having the person do some dancing. That would be a good way to, do large amplitude activities. It would also be good for balance. And then trying to combine in some counting once the person had the dancing activity mastered. The other thing was just trying to keep the person from sleeping and watching TV as much, just to keep them more physically active in that way.
Very nice. And then do you have anything to add for the create the 3 interventions?
Yeah, from the intervention, we discussed that we could use from the 4 areas we've mentioned in the first question. That was 1, modifying the environment by adding up some ramps or grabbing bars in the bathroom, and also the no movement, sedentary life, improving it, having more movement activities. The 3-inch lip in the bathroom should be modified also. Yeah, and the backyard had no steps or had no what there's the
Railing.
the railings. We also said that we should modify that. So those are the areas. Mostly it's more of modification and activity that involve movements.
Perfect. Thank you guys so much. Divya, if you have anything to add before we wrap it up, or if anyone has any other questions, please let us know.
No, this was great discussion. Sorry we didn't have much time to really go into the case study, but if you wanted to reach out about any specific concerns, I'm happy to answer as best as I can. And I do thank you for your time.
well, thank you so much for presenting. This was wonderful.
Thank you.
Great. Well, it's almost 3 o'clock, so thank you everyone for joining us, and I hope you come back in June and we'll learn about home modifications. Thanks, everyone.